Hello, and welcome to the Cardiac Catheter Labs here at Hammersmith Hospital, and welcome to this live from the Hammersmith demonstration. It's a pleasure to be broadcasting out today to everywhere around the world, and particularly today we've got colleagues in Japan and some colleagues in the United States joining us as well. So it's my pleasure to be here today in the labs, and I'm joined today by Drs Al-Lamee and Sayan Sen, many of whom I'm sure you know from the work in the field, and they will be performing the case alongside myself today. We're also backed up, of course, by a complement of physiologists and X-ray specialists in the lab here today, and it's my pleasure to be here, effectively moderating and leading this. Now, we're also lucky today, for the first time, in being joined by an expert panelist from Japan, and that's Professor Matsuo, who I think you should be able to see on your screen as well. This system we're using enables us to essentially interact directly with participants from all around the world, and also to stream out as well. So we're lucky to have Hitoshi joining us today, and he will act both as an expert from Japan to hopefully field some of the questions, but also ask me questions and then have the ability to translate back to you in Japan. Hitoshi, can you hear me?
Yes, I can hear you, Justin.
Very good.
It's my great pleasure. Yes, it's my great pleasure to be here, and it's our great pleasure to see a wonderful case demonstration using the ifr pullback system today. And on behalf of the Japanese colleague here, I would like to send sincere gratitude to you and your team for this very nice, beautiful live demonstration. Thank you.
Thank you.
And
thank you for your kind words. We'll try and do our best and make this an interesting case. As you know, this technology for the ifr pullback commercially is very new. In fact, we had the systems installed here in London in our cath labs only on Friday, so a few days ago. And so this would be the first case we actually perform using this technology live for you. So it's a real pleasure and honour to be here. Of course, we've done development work with this pullback device over the last year, so we have confidence in the device itself. But it's going to be exciting for all of us today. Now, if you can see from the slide, yes.
Yes. Can I explain in Japanese about the purpose of today's live demonstration to Japanese colleague? Okay. ですね、日本の皆さん、今日のライブデモンストレーションは、いわゆる ifr のプルバックシステムを使って、マルチベッセルの疾患を治療していくということを見せていただけるということです。ifr のプルバックシステムというのは現時点では日本では使えませんが、もうすぐ我々も使えるようになるシステムで、その有用性とか、あるいは疑問点何かありましたら、皆さんクエスチョン&アンサーという形で、質問を出すことができますので、よろしくお願いします。皆さんの画面の左上のところにクエスチョン&アンサーというのがボタンというのがありますので、そちらに、そちらを押していただくとですね、クエスチョン&アンサーをクエスチョンをですね、入れることができます。日本語でも結構ですし、ジャスティンらのチームの方々も、英語で書いてくれれば直接見ることができるような形になってますので、あるいは日本語で書いていただければ何らかの形で私の方から英訳して、ジャスティンに質問をするというような投げかけるという形で取っていきますので、よろしくお願いします。Justin, thank you. I will explain in Japanese about the system of today. The system, okay?
Great. No, that's fantastic. So I think everyone hopefully is clear about the question and answer. The philosophy of these presentations and demonstrations is really to merge the latest clinical techniques and to demonstrate them interfacing with clinical evidence, and really to hopefully help all of us to learn together and to improve clinical outcomes. And of course, this is an interesting case we're looking at today. So if we can look at perhaps the angiogram or describe the case here, and I've got a colleague alongside me, Dr Al-Lamee, who will effectively talk us through this very, very interesting case. Rasha.
Thank you very much, Justin. So this is a case of a 65-year-old male who basically came to us with exertional angina, CCS class 2, and was seen in clinic. At that stage, he had normal renal function, good LV function, and was known not to have any problems with peripheral vascular disease or COPD. He was actually recently diagnosed HIV positive and has now been put on retroviral therapy. He had a coronary angiogram with us back in November.
Great, well thanks Rasha, that's great. So this is obviously someone who's got extensive 3-vessel disease. Let's flick through the angiogram picture, that's great, thanks a lot. So you can see, firstly the thing which certainly jumps out and hits me is this LAD, which is diseased along its course, and perhaps there's a tighter area of disease more proximally. There's disease in the circumflex artery there you can see as well. And if we move ahead now to look at the right coronary images, or there's some more of the left there, so just highlighting the disease along the course of the LAD, you can see there's also some disease in the right coronary artery as well. So if you had a way of revascularizing patients without using physiology, it's likely in a case like this you may end up implanting many stents in the LAD, a stent in the circumflex and a stent in the right coronary artery. And we're really going to interrogate these vessels today along the lines of the Syntex 2 or FAME 3 protocol to see what actually needs revascularization with stents and what doesn't. Okay, so let's have a look at what we've essentially done so far. So we started the case around about half an hour ago. It's probably going to be a long case, this, because we're assessing lots of different vessels. And the first thing we did is to essentially look at the right coronary artery. So Chandra, if we can just flick to the right coronary artery roadmap, that'll be super. And just flick all the way through that. That's super, yeah. And there's the right coronary artery. So you can see Shai gave 300 micrograms of nitrates, and to make sure that the epicardial vessel was nicely dilated, and then the wire was passed down. Perhaps we could see that shot, the next shot on the angiogram runs here. That's great, and move on. And so that's normalisation of the wire, and I'm going to talk through that in more detail in a sec. And then the wire was positioned down beyond the stenosis in the next run. And then we made a measurement, and here we're using the very latest ifr software. And if we could see the result there, you can see that here's our value, very, very normal, of 0.99. Now what you'll see differs on this console from any that you would have seen before, and indeed this is, as I say, one of the first times I've used this system, is that now we see on every single heartbeat a green line which outlines the wave-free period. So this is new, helps to identify very, very clearly where we're actually making the physiological measurements, and you can clearly see in this case that these values are very, very normal. Okay, so that's where we are with the right coronary artery. So now we've got the left system, and let's have a look at the angiogram pictures from today for the left system. And you can see, as was the case before in the diagnostic pictures, there's disease in the LAD, and you can see there's one more focal area. Then there's another area just after that which is more moderate. Then there's a more intermediate area more distally, just as that bifurcation of a second or third diagonal comes off. And let's flick ahead. You can see on the other views much the same. There's a pinching of the proximal circumflex artery here as well. So what we're going to do now is we're going to effectively prep the pressure wire to go in, firstly to make a measurement of the circumflex artery, and then after we've done that, we're going to then go down into the left anterior descending artery, make a measurement distally, and then use the ifr Scout to do a pullback measurement down the length of the left anterior descending artery. So let's have a look at the pressure wire itself. We've of course already used the pressure wire for this patient, so what I'm going to do is going to show you a clean sterile pressure wire which is not for human use, just to show you how we will unpack the pressure wire, and then we'll move ahead to making the demonstration of the normalisation process and the rest of the mechanics via the wire which you've already used already. So you can see here that this is our pressure wire. It's out of the box, but it's still all packaged up nicely. And with all of these pressure wires now, and this is a Verata pressure wire, you can see that it comes with different instructions of kind of what to do and to talk you through it essentially. So the first thing is to flush. So I always flush with some saline. So here you can see I've got a 5 ml syringe, and I'm going to flush that. Now importantly, while I flush that there, you can see that the electrical connector is still closed off and sealed off in this other compartment. One of the common pitfalls which can occur is that you can get some water into this electrical connector here itself, and then that of course can cause a short circuit, and it can look like things like pressure drift or poor connection, but of course it's just like any electricity, it's just a short circuit. So what I will do now is essentially going to unplug this, I'll open up the container there, and I'm going to pass that over to a colleague, and then he will plug that in for us now. So what I'm actually going to do is plug over, yep, that's great, plug that in. And if we look at the Volcano screen now, we'll see that that's plugged in. And we just go to the screen, you can see it says waiting for 0 on the screen. A few seconds this takes. We'll flick across to live now. Waiting for 0. And then the wire's ready to insert. So this is a very, very important step here. Now the other thing which I just want to ensure, which you do absolutely adequately, is to make sure that our PA pressure has been zeroed as well. Of course we've done this at the beginning of the case, but I'm just going to check that for you again now. So the next thing I need to do is to open the port to air, and let's look at our physio screen there, and that's great. And let's can we just zero on the physiology screen? And we'll zero on the Volcano box as well. If we can have both of those on, that'd be super. So the Volcano box, let's just hold on, David, for a sec there. And that's great. And now that's great. So now we can go ahead and hit the 0 PA button on the Volcano box. This is very, very important step to ensure that the two systems here are talking to one another adequately. Once that's done, that's great. You can see it says 00 on the screen. We open the system back to the patient. Now we've got the patient's pressures back online, and we know that these have been properly calibrated now. So now we feel safe and secure that any measurements we make will be good. So the next thing I'm going to do is effectively just look at the pressure wire very, very briefly here. Of course, I've connected the pressure wire which we've used already, not the one which I've been unpacking. But just by means of demonstration, you can see that these pressure wires now come with a different connector. And you can see that rather than having to feed the wire into a little tiny hole, which has been the case for most of the life of pressure wires, now you can see there's an end-on connector, slides in very, very easily and simply, which enables us to connect and reconnect the wire during the time of the case. So this can be very useful if you want to perform PCI, IVUS, or other forms of imaging over the wire, or ballooning or stenting, of course, over the wire as well. So let's have a look and see where we are in terms of with our slide preparation here. We've done most of the initial steps. The next thing we'll definitely think about before making a measurement is to give the nitrates. Have we given nitrates here already?
We have indeed, yeah.
We have, yeah, good. So nitrates are very, very important, and I would always recommend as soon as the guide cath goes in, that is when you give the nitrates. And we'd recommend 300 micrograms of nitrates but before the wire goes in, and this is basically to prevent spasm and to ensure that the epicardial diameter of the vessel is as large as possible. Hitoshi, I don't know if you've got any comments with what we've discussed so far or need to communicate.
Yes, I think the initial preparation is very important for the measurement of this kind of systems. I think you said before doing the, for example, normalization, so we should give the nitrates before the pushing the wire to the vessel. Is that right?
I would, because I think that there's two reasons. One, it takes a few minutes for the maximum epicardial diameter to be achieved. Mm-hmm. If you give nitrates, you're going to induce very mild hyperemia. That takes 20 or 30 seconds to dissipate. And then also, it's like everything in medicine. Prevention is better than cure. So if we can prevent spasm from the wire, it's better to do it than actually to try and fix it once the spasm's occurred. Because, as you know, sometimes if you get spasm from the wire, we can't be 100% certain, even after giving nitrates, that it's completely resolved. So that's why I'd always give the nitrates, or recommend giving the nitrates up front.
Yes. Another point is to measuring the IFR. Probably the resting flow. We have to wait several minutes after the giving the nitrate, right? To measure the IFR, probably.
we know from some work which has been done that the hyperemic effect of the nitrates takes about 30 seconds to peak. And then the epicardial effects probably take another 30 seconds before they're maximised. So if you were to leave the pressure wire down, measuring the IFR throughout, and then give the nitrates, what you would see is the first thing you'd see is the IFR value would fall as you get mild hyperemia. But then as the epicardial vessel dilates, the IFR value rises and then stabilises. So what's better? The best approach is actually to do that up front, so you've given the vessel the most time for the epicardial artery to expand, and that's what I would recommend as the best way of making these measurements.
Okay. In case of the after giving the nitrate, how long we have to wait for the measuring the IFR?
So if you give the nitrates, I'd probably wait a minute. If you give heparin, a minute. Yeah, probably a minute is adequate. You'll see in almost all cases that will resolve. The only extreme cases I'd say is if you have a vessel which you've induced a lot of ischemia, or perhaps you've got nasty 3-vessel disease, and you've just got one vessel which is patent, and then if you give heparin or you pass the wire sometimes down, you'll induce ischemia itself. And in those situations, then you're of course in a situation where you know the vessel is very significant and you've got a very low threshold for treatment. But it's just having that knowledge to be aware that in those cases that things can differ. In 99% of cases that won't be the case, and 1 minute will be adequate.
Okay. Would you give me a minute for the Japanese audience? I will explain about this part. Okay.
Please do. While you do that, we'll go ahead and just advance the pressure wire and just wait at the ostium prior to normalization. But you carry on, Hitoshi.
Okay. 今デイビス先生がおっしゃられてたのは、ノーマライゼーション直後にきちんとナイトレイ亜硝酸剤の投与をきちんとしてくださいと。これはスパスムの予防ということもあるんですけれども、ワイヤーをこう、病変クロスしてリージョンクロスした後にナイトレートを入れるっていうのでは、その後のハイパレミックレスポンスっていうのがあるので、このタイミングっていうか最初の入れる以前に、スパスム起きない状況にしてからメジャーメントすると。今からノーマライゼーションとかやりますので少し時間がかかりますから、そういう意味ではハイパレミックレスポンスも消えた状況で、IFR を計測することができるということだと思います。Justin.
Fantastic. So that's perfect timing.
Yes, I will explain. Right. Perfect timing.
So Dr. Sen has got the wire up, so you can just see the tip is going into the circumflex artery now, and he's done that very elegantly. And so we're going to just pause there with the wire just at the ostium of the guiding catheter. And the next thing I'm going to do is once Dr. Sen has removed the introducer needle, and you can see we always do this routinely, is to remove the introducer needle. And indeed, we'll even do this for the pullback, and I'll show you how we do that in a second. We put the wire just perfectly positioned at the ostium. The port's closed up, and now if you flick to the physiology screen, the most important next step here is to do the normalization. Now, as you can see, in any of these normalizations, we want to make sure that we're not just looking at the numbers, we're not just making sure that that ratio is one, we're looking to see that we can see different features of the pressure waveform. So we're looking to see, can we see an aortic notch? Can we see a pressure wire notch? And that is very, very key to ensure that we've got appropriate normalization. So when you're happy that you haven't got a damp signal, we know we've normalized the PA pressures, so we know we've calibrated the table and the pressure wire console. We've got a beautiful high-fidelity trace here. We can now begin the normalization process. So I'll ask David just to press normalize for us there. And if we go to the live physiology screen, performing the normalization. And there you go. So very simple, takes 5 beats, and we have normalization done in a very, very straightforward and easy fashion. So once this is done, the next thing we're going to do in this case here is just going to pass the wire down through the circumflex artery beyond that proximal stenosis, and we're just going to interrogate this to see whether this needs a stent. Of course, in the old days, before FAME and FAME 2, the threshold here would have been very, very low to make a insertion of a stent in this case. Of course, we now know that really the real principal reason for stenting in intermediate and in even moderate lesions is really to help improve angina. we know stenting intermediate lesions is not necessarily going to help us with clinical outcomes. So we need to ensure critically that we have a lesion which has ischemia generating potential. And so now what we've done in this case is to pass the pressure wire down distally, and you can see in this case we're in the circumflex artery. It's a value which is very close to 1. Now this is a very interesting case. We'll flick to the live physiology screen here, and you can see a couple of things here. You can see on the new console here we've got the live IFR. So every single beat the live IFR is updated, and then every single beat you see the PDPA updated. Now one of the questions we frequently get asked, and Hitoshi, I would appreciate your translation here, is what happens in the circumflex artery if we get a value which is more than 1. And indeed this can happen frequently. This is not a problem with IFR. You can see the PDPA and the IFR here are exactly the same. This is what we call a hydrostatic problem, and it's particularly a problem with the circumflex artery which wraps around under the heart, and often the transducer can, the sensor tip can actually come up and actually be higher than where we're measuring with the actual aortic pressure transducer, and as a result you can have a positive pressure gradient. So in this setting here you can see that is the case. It's very, very mild and very trivial. We're not going to in this case, but if we were to advance the wire much, much further down the circumflex artery, and certainly in some circumflex arteries they're very big and they wrap all the way around, it wouldn't be uncommon in some cases to get a value of 1.04, 1.05. Now it's important to distinguish here between pressure drift and between this hydrostatic issue. And if we see this, there's no pressure drift, then it's purely a hydrostatic issue. And clearly, if the value is that normal, there's no need to implant a stent. So I'm not sure if you want a moment just to discuss that with colleagues, Hitoshi.
Yes, okay. 右冠動脈とか、それから回線子の IFR あるいは FFR も計測の時もそうなんですけれども 1.0 を超えることがあると、これはハイドロスタティックイッシュというふうにデイビス先生言ってみえますけれども、いわゆる大動脈のカテーテルの先端とそれからプレッシャーセンサーとの、高さの違いっていうのがあって、回線子あるいは右冠動脈の場合には1を超えることがあると。でただこれはドリフトとどういうふうに、区別をするかというと、やはりプルバックとかをきちんとしてそれはチェックせないかんということに最終的にはなるということだと思います。で今Justin, will you do the pullback here from now, right?
I think that one of the things, we'll talk more about the pullback in the LAD, is that if you've got an artery which is non-significant, then I think pullback's out of the question. If you've got an artery which is significant, then I think it's a good opportunity for performing the pullback measurement. Clearly here we've got a vessel which is very, very non-significant. So what I'd suggest is we move on and we go to the left system and then use the pullback device.
However, we have better to do the check of the drift phenomenon in the situations, right?
I think we should be careful here to check the just for any drift here. So what I'm going to try to do is just pull the wire back. We've been down here for 3 or 4 minutes.
Measurement first?
Yeah.
No, let's just check for drift first. I think you're right to be a little bit concerned here. So what we will do is just going to pull the wire back just to make sure that there's no drift. If there isn't, we'll advance back down again. If there is, we're just going to renormalize here. It takes a few seconds, but we're always very careful to ensure that there is no drift. And so let's just renormalize here. The wire was down there for 4 or 5 minutes, and once that's sorted itself out, that's great. We'll advance the wire back down, and then we'll just make an assessment of the circumflex, and then we'll move over to the left system.
このケースではドリフト現象は全然起こってないんだけれども IFR の値は1を超えるという現象は回線子とかではやはりよく起きえますということだと思います。
So I'm always very, very cautious wherever we make physiology measurements to make sure that we make the best possible physiology measurements, and we always like to make sure that we're making a measurement which, wherever possible, is free from pressure drift, free from any problems that we may be causing as doctors to not make a very good measurement. And so if you ever see anything which concerns you, it only takes a few seconds to make a drift check, to normalise once again, and then to repeat our measurements. Okay, so now we're in a good location here, and we've checked for the drift here again. We've normalised, and Dr. Sen has passed the pressure wire down again, and we've undone the port once again, and we've got a value which is very similar to what it was before. We've just got a little bit of ectopy there. Let's just go ahead and make a measurement though, guys, please. So we just hit record on the console, and just wait a few seconds here, and we should get a value. So there we go, 1.01. Let's leave that screen on there for a second. We need to save that frame. Now, one thing with this, can we just go to that image, please? The still image, David, thanks. The one thing which you'll see with this console is that, as we saw then, we expected a value of 1.01. We saw that from the live updated IFR measurements. But you can see it also labels the wave-free period. And here what we had is an ectopic beat. And this is often a question we've been asked before, is what happens to the calculations when you have ectopy. And previously I've always had to explain that the software is very, very good, and it's able to extract out the ectopic beats from the non-ectopic beats if it feels that it can't use that in the measurement. And here you can see that these beats with the red crosses on have been filtered out for the calculation of the IFR value. So we're really starting to use these technologies now to build on the technologies of the past, which just effectively averaged over all of these things, now to extract out beats which are less good from those which are better. So now what we'll do is we'll remove the pressure wire back and pull it back towards the ostium, just to check the normalisation. And then very, very soon after that, we're going to just going to move that into the left anterior descending artery, and to ensure that everything's okay. So while Shai's doing that, I'm just going to show you a few slides based around why we use IFR in which settings, and why we feel more comfortable to use to IFR. Essentially, the clinical evidence for this. So as many of you know, and many of you have been involved, we know that the IFR has been used now for a period of 3 or 4 years in clinical practice. And we know that in research practice, of course, it's been longer than that. And, of course, many of you have been involved with many of these studies. And, of course, any physiology is important because, remember, the two-dimensional angiography views can be deceptive. Here you can see if we fire the X-ray beams through this stenosis, you see it looks very tight. If you fire them through another direction, it looks far less tight and much more mild. And you can see in this very nice three-dimensional OCT fly-through, the reason for this is, of course, because using angiography, it's very, very difficult to see all the lumps and bumps within the vessel, the stenoses, the atheroma, calcium, and so what the pressure wire essentially does is integrates all this information. Now, if we look at the slide which shows us the clinical trial data to date, you'll see there's essentially 5 large studies which have looked at using IFR, and essentially these are the important studies which define its, firstly as a comparison to FFR, and then as a comparison to other third-party gold standards. So this is a comparison with IFR and other third-party gold standards. This is very, very key data. So the first study which we can see was the Clarify study, and this tested IFR and FFR against HSR, which is probably a gold standard stenosis pressure flow index. And this showed in a group of around about 55 patients no significant difference using HSR as the gold standard when comparing the FFR, which was measured with adenosine, and the IFR measured at rest. Similar study with 120 patients was independently analysed by Dr. Johnson and the team in Texas. And as you can see, again using HSR and the gold standard, the IFR and the FFR both very good in their diagnostic accuracy, and in this case the IFR was slightly superior. The next study came from the Amsterdam Medical Center from Jan Peek's team, and this used nuclear scintigraphy as the gold standard. And here you can once again see if you measure either at rest with IFR or BSR, which is a pressure flow index, or you measure pressure and give adenosine and measure FFR, there's again no significant diagnostic advantage. The next study was a study which looks at comparing IFR and FFR to flow. And once again, you can see here, the same as Dr. Johnson found in Texas with HSR, that there's actually a slightly improved diagnostic accuracy with regards to identifying low flow or normal flow patients with the IFR over the FFR. And key in this study, really, it was the first study to show that potentially in the intermediate zone, the relationship between IFR could be better with flow than it is with FFR and flow. So this is an important study. And the final study, which we'll look at, is essentially a PET study, which came out of a multi-center trial in the Netherlands. And this essentially used PET as the gold standard, which for many is, of course, the true gold standard. And it compared IFR and FFR, and again found there to be no significant difference. So these are all kind of key landmark studies.
Absolutely.
And what essentially we're going to do now is we're going to effectively build on that data and using the latest technology effectively to make IFR measurements using the ifr Scout tool on the pressure wire, just doing a slow manual pullback. So this is how we'll do things. Shai's very elegantly positioned the wire down in the left anterior descending artery. Unsurprisingly, you probably saw the values, or probably saw the stenosis and thought this was very likely to be significant, and indeed it is. But what I want to do is I want to firstly take you through how we actually do these pullbacks, and then I want to take you through some of the physiology to explain why potentially this could be superior to an FFR pullback. Okay, so the first thing I'm going to do is just explain to you how we make the pullback recordings, and for this it'll be very helpful to have a close-up of Shai's hands and on the actual cath lab table. So what we've actually done is the wire's been positioned in the distal left anterior descending artery. We've got the physiology screen on live. The next thing we've done is we've effectively taken the needle introducer out, as you can see there, and we've actually closed up the port fully, so there's no leaking blood or no leaking fluid out of that at all. Okay, so one of the things people
Justin,
yeah.
Justin, that's a moment. I will explain to the Japanese audience about what you will do from now. Okay.
Okay.
ですね、今 IFR のプルバックっていうのを今からLAD に関して、チェックするということです。で、IFR プルバックが FFR プルバックに関してどういう点で優れているかはおそらく後でジャスティンが説明してくれるんではないかというふうに思いますが、一応マニュアルでプルバックするっていうことを今からするんだそうですが、ジャスティン先生らはオートプルバックでやったりもされてますけれども、その辺に関しては後で質問したいと思います。Justin, thank you very much.
No problem.
Please go ahead.
So it's absolutely critical, and perhaps Hitoshi, it may be good to translate this as well, is that that port must be done up. Don't feel like you have to undo the port a little bit. The port can be twisted shut because you can pull the pressure wire back very easily with the port done up. If the pressure wire is effectively pulled back with the port open, the aortic pressure will move up and down, and you won't have an accurate FFR or IFR pullback. So that's very, very key, and it'll be excellent if you could just communicate that with colleagues in Japan as well.
ですね、今ジャスティンが言ってたのはなんていうんですか、あれなんていうんだ、ですね、酸欠じゃなくてですね、ワイコネのですね、入り口のところをきちんと閉めて、プルバックをしてくださいと。そうでないと圧がアオルティックプレッシャーがですね、不安定になって、なかなか美しいプルバックというか正しい IFR がビートバイビートで取れないということを、今説明してくれました。Thank you.
No problem.
Go ahead.
And I can also see on my screen that there's some questions which have come up in Japanese, Hitoshi, which I'll let you address, because my Japanese writing is even worse than my Japanese speaking.
Yes. Later I will ask you in English. Okay.
Okay.
As for the first questions, right?
Great. So Shai's down there. If we see the physiology screen now. We'll firstly record the IFR. So let's just record a measurement here. And unsurprisingly, as you may have guessed, the value here is very, very significant. So 0.76. For those of you who have seen the IFR cut points and are familiar with that and using this in clinical practice, we know a value of below 0.9, so an IFR of less than 0.9 is significant. So this is a very, very significant IFR value, probably in the order of an FFR of 0.66, something like that. So very, very significant value. So the next thing we're going to do is we're going to flick over to pullback mode. Just hang on a sec, David. And what Shai will then do is to pull the wire back very, very carefully, not altering or opening the TUI port at all. So if we can see the hands and see the physiology screen simultaneously, that will be super. And with the X-ray, that's great. He'll just pull that back very, very slowly. And as he does, not just yet. And as he does, you'll see. Yes, please, pullback mode. Let's go live now. He's going to pull that back very slowly. That's great, Shai. And as he does, you'll see the live blue line coming up, and you can see as he's pulling back, we'll expect to see some various lumps and bumps as he goes through these different stenoses, and we'll essentially see where the most focal part of the stenosis is. Okay, that's great. So if you just hold there, we stop the pullback, please. That's super. Okay, great. So this is a very nice pullback recording, and I'm just going to take a moment just to explain some of the different features on here. The first thing you'll notice is there's a solid blue line, and you can see on the solid blue line that there are some red crosses. Now, those red crosses are the same as the when we make in the individual measurements, and that's because this patient has some ectopy occasionally. So what the software does is it extracts those data points out, and it says, hang on, we need to be careful with these data points. We can sometimes include them if it looks like it's a reasonable data point, but if it looks like it's not a reasonable data point, then we want to remove it from the analysis. And you can see that's happened in a few locations, but we've still got a very nice recording, and we're still it's still very, very apparent where the big step-ups are occurring in this patient. Now what you can see is the distal vessel, the value rises very, very gradually, and there's a very slow rise in IFR till we get to this more proximal lesion, when all of a sudden we have this big step up in the IFR. That's great, thanks David, which is this proximal-most lesion. And now what we can do with this pretty accurately is use this in the context of disease which has got where you have tandem stenosis or diffuse disease with more focal stenosis, is actually to predict what the likely improvement of the value would be here. And you can see in this case the IFR value starts to rise from around about 0.78, and it probably peaks at around about 0.95. So we're looking for probably around about a 20 unit improvement in IFR. So probably just treating that one proximal single stenosis would raise our IFR value to around about 0.76. So you can very, very quickly see that this is a robust technique which enables us to identify diffuse from more focal disease in the coronary artery, and hopefully will mean that rather than having to make spot measurements as we've been doing at the moment, we can make a systematic assessment along the length of the vessel and just put stents in where they're needed, not where we think they're visually needed. So I think the physiology here is playing an important role. Hitoshi, I've said a lot there. I'm sure there's information to communicate there.
Yes, I would like to ask one question.
Sure.
In usual daily practice, we will routinely do the FFR pullback curve. In your experiments, are there any discrepancies between the IFR pullback and the FFR pullback?
Yes, there are. I mean, and as you know, that this is one of the big limitations of FFR, that you have, because the flow profiles of hyperemic flow is very different from resting flow. It means that you get much more crosstalk between lesions with FFR than you get with IFR. And you'll see on the slides, which I can show you, if we look at the hyperemic flow profiles, it's very, very apparent that, and here you can see a nice slide. This is from some of the original animal work from Lance Gould, now being replicated in humans as well. You can see as the stenosis increases in severity, that the flow falls off. Okay, so you can see about 50% stenosis, the flow starts to drop. Now, if we then see the effects of a stent in this location, so you've got two different lesions in this artery, and we start with a flow which is very low with a very severe stenosis. You put one stent in proximally, and then you re-measure the flow, it increases. So the flow increases. Now, what would this do to your FFR measurement? Your FFR value could be very low to start off with. You then put a stent in proximally. The flow increases, but you still have a distal stenosis, so the FFR value could actually be the same, or in some cases even lower. Now, with the IFR, or with the resting flow, you'll see a different pattern completely. Rest flow is preserved from 0 to around about 85-90%, and then it falls off as well. So if we put a stent in this location, the flow increases, but it only increases by a very, very small amount. So what this means, practically speaking, is that the interaction between lesions is much less with IFR than it is with FFR. And from a clinical perspective, this means that we can plan stent implantation and the likely benefits of stent implantation up front much better with IFR than we can with FFR. Now, we've analysed this systematically, and this is some work done by Dr Nidja, who's with us today, running all the technical side of things. You can see that in his analysis, doing just what we did today, so essentially he measured, he did a pullback, he then estimated the likely improvement, they then put a stent in and then measured the IFR afterwards. The difference between the predicted and observed was tiny, so clearly non-significant. So this is an important development here, and you'll see that as things continue to evolve and as the upgrades come through, one of the key things which will happen beyond this is that you'll start to see the IFR pullback integrated more with the angiographic images. And you can see this on this multimodality image here, whereby you see, firstly we take the angiogram, and then essentially what we do at each location, we track the pressure wire as it's pulled back very slowly, just like Shai did today. And at each location we record the physiology values. Now this system is very clever, so it's got something called Coregistration, which tracks the marker location, and if you know the location, effectively you know the distance that you've pulled the wire back, and that enables us to calculate the gradient, or the amount of energy which is being lost at each level of the artery. And you can see in this screenshot here that this vessel is significant, and you can see along the length of the vessel there's areas where you only have a few red dots, where there's only a little amount of energy loss, and areas where you have lots of energy being lost around the stenoses. So a combination of this map will tell you where most of the energy is being lost, and we can use this then in a predictive model to know how best to treat our patients and to guide where to position stents.
Justin,
Yeah.
I will explain in Japanese about this part to
Okay.
the audience, okay?
No problem.
Okay, so, ですね、今、デイビス先生がご説明になってたのは、その IFR プルバックっていうのは、例えばタンデムリージョンにあったときに、例えば一箇所にそこのステップアップがですね、タンデムリージョンがあったときに、その一箇所にステントを置いた場合、おそらく予測できるようになるんですね。つまり IFR がこのケースですと 0.6 で真ん中の部分が例えば 0.2 のステップアップがあった場合にはそこにステントを置けば IFR は 0.8 になり得ると。それはなぜかというと安静時の血流量というのが基本的にステントを1個置いてもですね、よほどもう一つの病変が高度でない限りには変わらないので残りの圧格差というのはフローが一定なんで抵抗血管の狭窄があった場合にですね、そのプレッシャーのドロップの量というのは変わらないということで、いわゆる治療前にこのステップアップのパターンからどのくらい改善できるのかということが予測できると。それがその予測値と実際にステント入れた後の計測値のなんていうんですか、相関係数が 0.94 とかですね、非常に高い値になるということを言われてまして、で今画面に残っているのは今マニュアルでプルバックしてましたけれども、 暗行とコレジストレーションすることによって、どこの部分でどのくらいの圧迫差があるかっていうのを、ああいう形で画像化することができて、どこにステント、どこからどこまでステントを送ると、どのくらいのドット、1ドットっていうのは、IFR の値で 0.01 を示してるんですけども、それが10個固まってるところにステントを置けば 0.1 の IFR のステップアップが得られるということが分かるということを説明していただけたと思います。Justin, thank you.
No problem. Well, thank you for your explanation there. The one thing also I'd like to, we've got a question which has come through about how fast you should pull the wire back. This is often a question we get asked, and I'm sure that as each of you have the opportunity to use the system, you'll soon realise it's not really a very big issue. You saw Dr. Sen pulling the wire back, and he just pulls it back slowly as you would pull back a normal pressure wire for a pullback or an IVUS catheter. Very, very slow, gradual pullback. Don't worry about pulling it, that you're pulling it back too fast or too slow. It's just a kind of normal rate which you'd pull it back over 15 or 20 seconds, and then we get the answer. In this case, you can see, I think the whole pullback after we'd had the initial start-off phase, the run-in phase, was around about 25 seconds. So that's fairly typical. That's a long LAD we were assessing there. I don't know if you just want to communicate that, Hitoshi, to the audience.
Yes. どのくらい、早く引くのかということ、質問がクエスチョン&アンサーで出てましたけれども、できるだけゆっくり、例えば20秒とか、少なくとも7秒以上かけないとこのシステムはラインができないですね。このスコートシステムっていう IFR プルバックシステムでは、7心拍か。7心拍以上は絶対にプルバックの間にないといけないということが決まってるんだそうです。それ以下だとああいうラインは作れないと。だから基本的には非常にゆっくりと弾くっていうのが、例えばノイズ成分を減らすとか、そういうことにもやはり、なんていうんですか、役に立つ、綺麗なカーブを得るには、やはりできるだけゆっくり弾くっていうことが大切だということだと思います。So you recommend more than 20 seconds, right?
I think it depends on
it's too long?
It depends on the length of the vessel. So if it's a long LAD, a long LAD maybe 20 seconds. If it's a shorter circumflex artery, maybe 15 seconds. But in reality, I would recommend not worrying about it, because actually people are very, very used to pulling back at that speed normally. So it's just a normal slow pullback, and not be worried about the time. It's the most important thing is that they start the pullback and they continue all the way up to the left main stem in one constant motion. That's the key thing. No stopping or starting, just start distally and continue all the way back up to the main stem. This way the system can best calculate out where the step-ups are, and it makes things work very, very smoothly and simply.
I see. つまり非常にゆっくりとかつ、一定のスピードで弾くことが大切であると。止めて弾いて止めて弾いてっていうのはやっぱり避けた方がいいというお話でした。Thank you. I explain in Japanese.
Yes, so that's very, very key point. And so in this pullback speed, don't become obsessed. Don't worry about it. But the most important thing here is just to pull back slowly and in one continuous motion, all the way from the bottom to the top. Don't touch your port, the aortic pressure port. Just make a continuous recording. And here you can see on the screen another recording where from a similar case to today, where you see diffuse disease, you have more severe disease, and more diffuse disease again. Now, one of the other options, perhaps, David, we could just flick to if you go to the options menu here. If we go to options and we go to no, I think we've got it on already. That's great. So in fact, let's go back to that options menu. I was just going to show you what the potential things you can do here. You can often change the pressure scale, and you can change, and we won't need to do it in this case, the IFR pullback range. This is set dynamically, but if you ever wanted to zoom in or out a bit more, you could do that. And then we've got the ability to show a raw pressure line or show the wave-free period, which again are options if you've ever got any concerns. So let's come out of that menu now. The other key thing which I'd just like to warn everyone about, which is very, very important for understanding how this works, and again, if we look back at the physiology slides of the flow, that would be helpful, is that with both FFR and with IFR, we have to, of course, respect the coronary physiology. And you'll see when you come to a stenosis which is 90% or more for both hyperemic measurements or non-hyperemic measurements, that's essentially where that last dot is on both of those two slides there. There you go, thanks very much, Luke. We have to be careful when you get stenosis more than 90%, because in these cases the flow starts to fall away. And if the flow starts to fall away to an extent where there's not much flow going down the vessel, this can lead to effectively underestimation of the lesion severity, and it can lead to the FFR or the IFR value being incorrect. And also this can lead to effectively this independence of one stenosis from another disappearing. Now, I'm warning you this just to be cautious, but more as an educational note, because what we do know is these stenoses are usually very, very tight. So a 90% angiographic LAD stenosis is very, very severe. Probably today it was around about 80% this LAD, and it looked quite tight if you measured it formally by QCA. So just bear in mind, if the stenosis there is more than 90%, the natural physiology would be that flow starts to fall off, whether you're measuring with FFR or IFR, and you just need to be cautious. Hitoshi, I'll hand over to you just to cover that.
Yes. 90% 以上の高度狭窄っていうのは、IFR にしろ FFR にしろフローが基本的には非常に低いレンジに来るっていうことで、ただそのいわゆる狭窄度の評価というか、フィジオロジカルに狭窄度を評価するのは非常に難しいだろうと。やっぱり 80% 以下の狭窄の評価にこういった指標というのは使われるべきだということだと思います。で、レスティングフローというのは 80% 以下の狭窄ではほぼ一定というふうで、一定、それに対してハイパーレミックフローっていうのは 50% から 80% の間ではこれだけの違いがあるんで、ハイパーレミックフローの場合にはそのフローが増えれば圧格差は大きくなるっていうようなことがあるということですね。ですからそのプルバックの時にタンデムリージョンを評価する際には、その IFR の方がおそらくベターであろうということで、90% 以上の高度狭窄ではこういった指標はちょっと使えないということをデイビス先生は言っておられます。Thank you.
No problem, Hitoshi. So, I mean, I think that we've demonstrated today the use of physiology nicely. And indeed, I think this is the important way how physiology is going to be used in the future. Previously, we would have had cases where there was multi-vessel disease, and you would have jumped in and stented all three vessels, and you would have had no kind of regard for the underlying physiology. Quite clearly here you can say that two of these vessels are completely normal and one is likely to be causing all of the problems here. Now, I think there's a question which has just come in with regarding this slide which Dr. Nidja showed you, and that was from another case completely. So that's showing an IFR value of 0.85. And perhaps why don't you show that case again, Suk? And that's just from an illustrative slide. It's not from today's case, but it just very nicely illustrates in a similar way to today's case how the IFR values can change. So that's pre-prepared PowerPoint from another slide, another patient. And then if we flick to today's live values, you'll see, strangely enough, we have very similar data, whereby we have diffuse disease and then a more focal disease, but clearly these are very, very different numbers and different patients. So, Hitoshi, we've got about 3 or 4 minutes left. I'm not sure if there's any questions which you've got for me, or anything you'd like to address to the Japanese panel.
Yeah, there is one question from the audience. This is a question about the normalization of this system. Usually, FFR, as for the measuring of the FFR, normalization is just done once. However, in usual practice, as for the IFR, we usually do more than 2 times normalizations. Is it necessary, or do you think 1 time is enough for the normalization?
Well, I can tell you that, and as you know, in the FLARE study which we're doing, and indeed any of the big studies, people have always been very, very careful with normalization. So whereas it's tempting clinically to try and speed through things, I think that we need to be absolutely careful to make sure we're getting the best possible physiology results. So in the FLARE study, which is a very, very large study, as you know, with a number of centres from Japan, including yourself and Dr. Tanaka, involved in the study, we have to document normalisation at the beginning and save an image. We make the measurement, and then we return back afterwards and have to document normalisation again as well at the end of the case. Now, we do this because we know very small amounts of drift may occur, and this happens with all of the pressure wire systems, but we need to make sure that the value we're recording is accurate because we're making clinical decisions on this. We do this for both arms. This is the IFR arm and the FFR arm of the study. Both you need to be careful to make sure that you're making measurements as free as drift as possible, and when that does occur, if there's significant drift, more than 0.02 in the study protocol, we'd recommend remeasuring again. This is not an IFR phenomenon, it's not an FFR phenomenon, it's the fact that the pressure wires are a little bit drifty, and all the systems have this, and we just need to make sure that when we make our measurements, we do it as accurately as possible.
Yeah, I think I agree with you in that IFR is a very sensitive value, and we need the normalization is one of the key to measure the correct measurement, right?
Absolutely.
To do the correct measurement. So, for example, if we can't get the complete normalization by two times normalization, probably we need the third or 3 or 4 times normalization is necessary. Is that right?
I think it's unusual. I mean, very occasionally you'd have a problem maybe with a wire which was not working as well as it should do. And I think that if you have a problem normalizing, then that's an issue which the wire potentially needs to replace. If that's not the case, in almost all cases you can normalize the first time you go down and there's generally not a problem. So I think there's two things. One is making sure you can normalize the wire. And if you, so usually that happens pretty slickly. And the other thing is just to make sure at the end of the case that you ensure that there's no significant pressure wire drift and to recheck. So there's two different things there. But both are very, very important. And they're both important for both the IFR and for the FFR as well.
I see. Thank you very much for the very good comments. 日本語でちょっと福山先生からのご質問で IFR においてノーマライゼーションは、2回ノーマライズが必要と聞きましたが、1回でコンプリートにできればもちろんいいんですけれども、2回3回ときちんとノーマライズするっていうのが大切で、何回もするっていうことに関しては問題はないでしょうかというご質問でしたけれども、何回やってもいいと思うんですね。きちんとノーマライゼーションができるまでやっぱりやるべきかというふうに思います。以上です。Thank you, Justin. I will explain in Japanese, okay?
Fantastic. So I think we're pretty much at the end of this demonstration today. I hope it's been something which has been informative and interesting for people to see. You can clearly see that this technology is very straightforward and easy to use. As I said, it's the first experience we've had today. And I think that using physiology, both in the studies such as Syntex 2 and FAME 3, will definitely prove the potential for altering the way we do PCI in the future. I think it's likely to mean that we do probably put less stents into individual patients, but perhaps there are patients at the moment who are getting medical therapy who will need stents. Those who are potentially we think have got tight lesions will need medical therapy. And I suspect as we find over time, particularly us in Europe and in the United States, patients who are going for bypass surgery, well, more of them will be coming to the cath lab for interventions. I know in Japan you don't do that many bypass procedures because you do more PCI, but I think you'll find that even fewer of the bypass cases will be going to surgery and more will be coming to the cath lab. So with that really, I will probably sign out and say goodbye here from London today. And I'd invite any of you to, if you've got any questions, to please email myself or the rest of the team, or to look on the website, which is simplephysiology.info. It's a new website which the team here has put together, and it provides much of the information that you've seen today. In this case, lots of slide decks, lots of useful information about the courses which we run as well. So Hitoshi, I think I'll sign off and say goodbye to you, and I look forward to seeing you shortly in the ACC.
Thank you very much. On behalf of Japanese colleague, I would like to send our sincere gratitude to you and to your team.